Hello and welcome to the Unit 12 presentation on cognitive processes for nursing fundamentals. So cognition is being able to speak, see, process information, remember, and problem solve. Nurses play an important role in identifying patients at risk for and suffering from cognitive impairments. These are your learning objectives for cognitive impairments. Please be sure to review them in preparation for class and for the exam. So in order to plan and evaluate nursing care, first you have to understand normal cognition and the factors that place patients at risk for impairment. Perception is being able to sense and interpret stimuli. Consciousness is related to the RAS, or reticular activating system. This is discussed more in the sensory lecture. Consciousness is awareness of what's around you. Thoughts involve being able to pay attention and learn from things like this boring PowerPoint. The stimulated area of the cortex determines discrete characteristics of thought, such as what is seen in the visual field. Immediate memory lasts for a few seconds to minutes. Intermediate memory lasts for a few minutes to weeks, but it will be lost unless the memories are changed into long-term memories. Long-term memory lasts indefinitely and involves the hippocampi. Stress can impair short-term memory, and a continued memory impairment indicates a central nervous system disorder or a severe confusional state. Speech comes from the left side of the brain, so think about what's happening to your patient. Is it a stroke or brain injury? The location of the damage determines the cognitive deficits. So we know that it's hard to concentrate when we're under a lot of stress. So for example, school, marriage, work, children, illness, finances, or family issues can significantly affect normal cognition. For adequate intelligence and comprehension, we have to be able to concentrate. Intelligence is the measurable product of intellectual functioning consisting of memory, comprehension, and concentration. Reality perception is the awareness of time, place, and yourself. Those with depression have oftentimes alterations in reality perception. Orientation. This is where you are in the dimensions of time and place. Just think about if you woke up and didn't know where you were or what time it was. It can be very scary for patients who are disoriented and are really experiencing this kind of thing. Judgment is having insight and the process of reasoning. Recall and recognition is being able to retrieve information from short and long-term memory. Language is being able to convey needs, ideas, and feelings. There's a lot of things that affect cognition. Anytime there's a lack of blood flow or oxygen to the brain, which is known as hypoxia, there's a risk of brain damage, which shows itself as altered cognition. Some patients with hypoxic brain injury wind up in a persistent vegetative state and never recover their cognitive function. Fluid and electrolyte balance, such as decreased sodium, decreased blood sugar, increased ammonia levels, and increased calcium levels can cause confusion. Elevated blood sugar can cause difficulty concentrating. Adequate sleep is necessary for consolidating learning and moving information from short-term over to the long-term memory. This is why it's so important to get sleep before a test. You're going to remember the material better and you're going to be able to recall it for the test. Self-perceptions influence our cognition and how it's portrayed to others through communication. This is how we see ourself. Infections such as sepsis can cause confusion. Also, encephalitis or brain inflammation, brain abscess, or AIDS all cause confusion and altered cognition. Head trauma can cause significant changes in cognition and behavior as well. Assessment tools are used by healthcare providers to assess level of cognitive disorder. The exams test patient recall and ability to follow commands. The tools listed here are examples of ones commonly used. For example, patients are asked to draw these 10 angles and 2 of the angles must intersect. If they can't do this, then there's a problem with cognition. Copies of these are included in your readings on E360. Labs and imaging are also indicated to rule out causes of cognitive changes, such as checking the sodium level or checking to see if they have a stroke with a CT or an MRI. Patients showing disorganized thinking can be difficult to interact with because they're not able to follow a logical sequence or respond predictably or rationally. They may have delusions or hallucinations. Delusions would be something like a patient believing that they're in control of the weather and can make it snow, or a belief that someone's out to get them, even though there's overwhelming evidence that it is not true. A hallucination would be a patient seeing bugs crawling on the ceiling or hearing voices that aren't really there. The challenge with these types of patients is that their delusions or hallucinations are very real to them, so it's very difficult to orient them to the reality that really is going on. Anyone showing abnormal levels of arousal, attention span deficits, or memory impairments that affect judgment, insight, planning, or problem solving have impaired thought processes. Delirium is characterized by its acute or sudden onset, and it can affect patients of all ages. Dementia, on the other hand, is chronic. It happens over time, and it typically affects the elderly, but it can be earlier age of onset also. Depression is a low or depressed mood. Depression happens to people of all ages. It is not a normal part of aging, and it is treatable. Symptoms of depression in the elderly can be forgetfulness, increased fatigue, definite change in mood and behavior, and suicide risk. Up to 30% of elderly with major depression express suicidal ideation. So it's very important to assess these patients, and if we suspect suicidal ideations, ask them directly about it. Do you have a plan? Do you have means to commit suicide? Because we need to assess this and then intervene if necessary. Again, delirium is acute with a sudden onset, and it can be very common with acute infections. Delirium is common in the hospital setting due to altered sleep patterns and sleep deprivation, among other things. You know, we're always waking patients up, and it's a very noisy place to be. It affects up to 30% of people on general medical floors and up to 80% of patients in the critical care setting. Another name for severe delirium in the critical care is ICU psychosis. Examples of delirium include DTs for people withdrawing, sundowning, which is nocturnal delirium, schizophrenia, which is distortion of reality, and CCU psychosis, like we mentioned before. It's the RN's responsibility to implement delirium prevention strategies and monitor for signs and symptoms of delirium. Examples include minimizing benzodiazepine use, managing sensory needs, use glasses, hearing aids, early mobilization, promote sleep-wake schedules, frequent reorientation to time and place, and to minimize noise. Dementia, unlike delirium, is a chronic progressive decline in cognitive function. Dementia gets worse over time. There's no cure, but there are some medications called acetylcholinesterase inhibitors that might help slow the progression of Alzheimer's dementia. Alzheimer's is the most common form of dementia. Neurons degenerate from an unknown cause. There's 7 stages of the disease, and this ranges from mild cognitive impairment to severe impairment that could be so severe that the person loses the ability to care for their own self. And eventually they die from loss of ability to swallow, or starvation, or infection related to diminished immune status. Lewy body dementia is the second leading cause of dementia, and it affects over 1 million people. It's caused by the development of something called Lewy bodies in the nerve cells of the brain. It's caused by protein deposits on the nerve cells. Signs and symptoms include daytime drowsiness, rigid muscles, and visual hallucinations. Parkinson's usually affects people over 60, but this can happen earlier too. It's a neurocognitive disorder characterized by tremors and rigidity, and in its later stages, progressive dementia. What's neurocognitive impairment? Well, this is confusion, fogginess, or a loss of short and long-term memory. Defense mechanisms are used by the person experiencing dementia in an attempt to maintain self-esteem. The patient may be in denial of the situation, or the patient might make up stories to cover events they don't remember. This is called confabulation. Perseverate is the patient avoiding answering questions by repeating behaviors. Caregivers face definite challenges when dealing with dementia patients. Remember, their behavior and possible aggression is not personal. They're just having a lack of control, and they don't know any better way to get their frustrations out. Dementia and Alzheimer's can be a huge stressor for patients and families also, so having support systems in place can help considerably. And this slide just lists some information about that. So what can we do for dementia patients? Well, main interventions or techniques to use with dementia or Alzheimer's patients should focus on safety and reassurance first. And this is safety and reassurance to the patient. Reorientation to person, place, and time tends to make the situation worse. If the patient doesn't remember their loved ones in the present time, we could encourage them to reminisce about the past, which they might remember. So for example, if a patient doesn't remember their brother, rather than saying, "Mr. Smith, do you know who this is?" when the brother visits, instead say, "Mr. Smith, I remember you telling me about the adventures you've gone on with your brother. Tell me more about him." This avoids putting the patient on the defensive if they can't remember who the person is with them now, but it allows them to draw on distant memories which might remain more intact. It can also help put the family member more at ease because even though the patient doesn't know them now, they're still verbalizing about past experiences. Aphasia can be devastating to patients and their families. Expressive aphasia is difficulty getting words out. Receptive aphasia is difficulty getting words in or understanding. They might speak normally, but it might not make much sense in the context of what you're asking them, because they don't understand what you're asking them. Global aphasia is difficulty getting words out and in, so they can't talk and they can't understand. And then dysarthria is slurred speech. So simple questions with simple answers rather than open-ended questions are helpful when communicating with patients with impaired communication, whether it's related to aphasia or whether it's related to dementia-type problems. There are many nursing diagnoses that could be appropriate for patients with impaired cognition, depending on their unique situation or level of impairment. This slide lists a few of them, but there's a lot more depending on what's going on with your specific patient. So some more interventions are things like health promotion, nutrition, exercise, stress management, socialization. Memory improvement includes stress reduction, adequate sleep and rest. Mental exercise like crossword puzzles can be important and helpful. We can use therapeutic communication with our patients, and we always should try to do this. We can reorient to person, place, and time as appropriate, but like I said, sometimes this can make agitation worse if the patient has dementia. In this case, use things like calendars, clocks, and appropriate light-dark cycles, keeping the shades open in the daytime and shut at nighttime, rather than directly reorienting the patient. Redirection or distraction is more effective for dementia. This is getting them focused on something else if they are going down a trail that they shouldn't be on. Alternative communication, things like word, letter, or picture boards can be helpful for patients with aphasia. We can maintain a safe environment by using bed alarms or wander bracelets that the patient wears. This is something that will alarm if the confused patient wanders out an exit door. So then we know that they're leaving the facility and we can go after them. Night lights are also helpful so they don't trip when they get up. And then provide familiar surroundings like familiar objects from home, which can help ease agitation. The last phase in the nursing process is evaluation. If goals and outcome criteria were met, revisit the nursing process, or if they were not met, revisit the nursing process and see where changes are needed, and then start again based off of that. This concludes our presentation on cognition. Be sure to view the presentation on sensory as well. Thanks for watching and have a great day.